Sir, we are live now, sir.
Yeah, thank you, Chitrakala. Ma'am, with your permission, shall I start?
Okay, start,
Yeah.
please.
Thank you, ma'am. Good morning, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Rashmi Prasad, who is an infertility specialist at Divya Vasalya Mamata Fertility Center, Patna. She has done her medicine and DGO, and also she has done her PGD in ART and reproductive medicine from University of Skillswork, Holstein, Kiel, Germany. And with this, we welcome you for today's webinar. And as you know that today's presentation is streamed through the Shield Connect, which is a digital platform of Shield. I request all the delegates, please do visit the Shield Connect. And if you miss any part of the program, it will be available in the Shield Connect. And coming to the today's topic, as we know that women with very low AMH levels undergoing IVF still have a reasonable chance of achieving a pregnancy, and low AMH have a good impact on the success of IVF. So without wasting much time, let me turn over the time to Dr. Rashmi Prasad ma'am to talk on influence on AMH in IVF success. Over to ma'am.
Thank you. Good morning, everyone. As doctors mentioned that AMH has the tremendous effect on AMH. AMH has tremendous effect on the outcome of the pregnancy or IVF. So let me brief what is the full form of the AMH. It is called anti-Mullerian hormone. The doctors who is very new to the infertility world, one should know the AMH. It has the great value to the success of the IVF. So in any ladies, when the age advance, AMH level gradually declines. AMH shows the storage of the egg in the ladies, in a particular ladies. So one should be very careful about during the stimulating to form the follicles. We should have the proper knowledge of the AMH level. So please scroll the screen. Next slide, please. So let us come to know some information about ovarian reserve. Okay. Scroll नहीं हो रहा था. अब हो गया scroll. मजा ठीक है. So let us come to the definition. The ovarian reserve is constituted by the size of the ovarian follicle pool and the quality of the oocytes. Ovarian reserve decline with the increasing age, resulting in the decrease of the women's reproductive functions. There is considerable individual variation in the age of menopause and subsequently also in the age of subfertility. Hence, the chronological age is a poor indicator of the reproductive aging and those of the ovarian reserve. So, ovarian reserve assessment, how one can do the ovarian reserve assessment in a ladies who come for the IVF. This test includes anti-Mullerian hormone. As I have already said you before, that anti-Mullerian hormone AMH is one of the most important indicators for the ovarian reserve. Other parameters are follicle stimulating hormone on the day 3 of the cycle, inhibin B on the day 3 of the cycle, estrogen, E2 level, antral follicle count, ovarian volume assessment, and clomiphene citrate challenge test. However, there are potential limitations associated with each of these tests. So, follicle stimulating hormone test, easily it is done on day 2 or day 3 of the cycle. Women with more than 10 IU per liter indicates poor response to the ART. As you see in the graph, or if the FSH level decide the quality of the egg, quantity of the egg, and the age also decide the quantity of the egg, which leads to the number of good embryo and delivery rate is affected. Now, variation from the month to month, FSH level variate from the month to month, from this menstrual cycle to that menstrual cycle. Lab-wise variation is also seen in value due to the different techniques. Spurious fall after the hormone therapy is seen in the FSH level. and sensitivity to the predict ovarian response is poor. Ovarian reserve marker, serum E2 level alone is of little value to assess the ovarian reserve. Progesterone does not have any independent role in assessment of the ovarian reserve. Early LH surge and elevation of P4 suggested sign of the poor ovarian reserve. Inhibin B produced by the granulosa cells. A fall in day 3 inhibin B level may predict poor ovarian reserve before the expected rise in the day 3 FSH, but it has high false positive rate. Level less than 40 picogram per ml shows poor response to induction. Factor affecting inhibin B measurement, obesity, in this case decreases, PCOS, it increases inhibin B. Exogenous FSH administration increases the level of inhibin B, and the oral contraceptive use decreases the level of the inhibin B. Antral follicle count, which can be pronounced as a AFC in the short form, count of the total follicle measuring 2 to 5 mm in the both ovaries on the day 2 or day 3 of the periods called AFC. So for assessment of the number of follicles by ultrasonography, the antral follicle count best predict the quantitative aspect of the ovarian reserve. Some correlation with the ovarian response, but only at the lower threshold. If the AFC is less than 5, it shows worse outcome. Factor affecting AFC measurement, oral contraceptive use decreases AFC, PCOS increases AFC. As you know that in PCOS there is number of the follicles, so there is more follicles is detected on the ultrasonography. Drawbacks of the AFC, accurate measurement, accurate assessment of AFC requires an experienced sonographers and can be limited in the patient who have had pelvic surgery or uterine fibroid and in those who are obese. Moderate inter-observer intercycler variability of the AFC determinations limit its reproductibility. As with the basal FSH measurement, the intercycle variability of the AFC does not correlate with the IVF outcome in the individual patients. AFC can only tell the number, not the quality of the oocytes. So, scroll करो आगे.
Excuse me.
ये आगे forward. AMH, French endocrinologist discovered anti-Mullerian hormone or Mullerian inhibiting substance. It is a dimeric glycoprotein hormone belonging to the transforming growth factor beta family. It is produced by Sertoli cells of the testes in the male and produced by the ovarian granulosa cell in the female. Dynamic changes AMH level and change in the number of the AFC with age. It is shown in this graph. As you can see that the figure based on the studies by Fedi reporting that number of the primordial follicles was 6 to 7 million during fetal life and approximately 1 to 2 million at the birth and about 3 to 5 lakhs at the starting of the puberty and 1,000 at the age of 51 years of age. As you can say that with the increase in the age, the decrease in the AFC level. Pathophysiology, male fetal development, AMH prevents the Mullerian duct from developing into uterus and other Mullerian structure resulting in the normal development of the male reproductive tract. In absence of AMH, the Mullerian duct and structure develop into the female reproductive tract. AMH serum concentration are elevated in the male under 2 years old and then progressively decreases until puberty when there is a sharp decline. So female AMH is also expressed in the follicle of the female of the reproductive age and inhibits the transition of the follicle from primordial to the primary stages. Follicular AMH production begins during the primary stage, peaks in the pre-antral and small antral stages, and then decrease to undetectable concentration as follicles grow longer. By contrast, AMH concentration are low in the female children until puberty. Concentration then declines slowly over the reproductive lifespan as the size of the pool of remaining microscopic follicle decreases. AMH concentration are frequently below the detection limit of the current assay after natural or premature menopause. Model of the AMH action in ovary, progressing stages of the folliculogenesis are depicted. AMH is produced by the small growing primary or pre-antral follicle in the postnatal ovaries and has two sites of the action. It inhibits initial follicle recruitment, one, and inhibits FSH-dependent growth and the selection of the pre-antral and small antral follicles. As you can see in the diagram, that is primordial stage, primary and pre-antral and antral stages. Ovarian reserve, as you can see that hypothalamus triggers pituitary, which leads to the LH and FSH secretion, which leads ultimately reversely to the AMH level or inhibin level, inhibin A, B or E level. In the older, the situation will be reversed, AMH will be less. And as you can see in the screen that how with the in the younger age, in the older age, there is a lot of variation in the hormonal age. So ovarian reserve is a complex clinical phenomena that is influenced by the age, genetics, environment, and variables. Why AMH better for the ovarian reserve? The question arises because of the gender difference in AMH concentration. It changes in circulating concentration with sexual development, and it is specificity for the Sertoli and the granulosa cells. Since AMH is produced continuously in granulosa cells of a small follicles during the menstrual cycle, it is superior to the episodic release gonadotropin and ovarian steroid as a marker of ovarian reserve. Furthermore, AMH concentration are unaffected by the pregnancy or use of the oral or vaginal estrogen or progesterone-based contraceptives. AMH normal range, it varied from the lab to lab, but there is some range which is mentioned on the screen: high, normal, low normal range, and low and very low. Which high category is over 3.0 nanogram per ml. Normal is considered over 1.0 nano ml. Low normal range is between 0.7 to 0.9, and low is 0.3 to 0.6, and very low is less than 0.3. But it is not very fixed. It, as I have already said, it varied from the lab to lab. Most in our practice, we consider less than 2 is low. Use of AMH assessment of the menopausal status includes premature ovarian failure, assessing ovarian status including follicle development, ovarian reserve, and the ovarian responsiveness as a part of an evaluation for infertility, and assisted reproduction protocol such as in vitro fertilization. Assessing ovarian function in the patient with polycystic ovarian syndrome, evaluation of the infant with ambiguous genitalia and other intersex conditions, evaluating testicular function in infant and the children, diagnosing and monitoring patient with anti-Mullerian hormone secreting ovarian granulosa cell tumor. So anti-AMH level are indicative for the size of growing follicle pool and considered as a marker of ovarian aging. AMH level decline with the age. Hence, decline in the AMH level may be the earliest marker of the ovarian aging. Change in the serum AMH level occurs relatively early in the sequence of event associated with ovarian aging. Change in serum level of the FSH, inhibin B and E2 occurs relatively late in the reproductive aging process. There is a strong correlation of the serum AMH with AFC, antral follicle count. AMH is the marker of the ovarian responsiveness in the women undergoing treatment for infertility. It helps to predict outcome of the IVF procedure. Ovarian reserve response and cumulative live birth rate of the women undergoing in vitro fertilization who had discontinued anti-Mullerian hormone and anti-antral follicle count. There are various studies. Aim of the studies are to evaluate the ovarian response and cumulative live birth rate of the women undergoing IVF treatment who had discordant baseline serum AMH level and AFC. Among them, those having higher AMH within the same AFC had higher number of the retrieved oocytes and cumulative live birth rate. In vitro fertilization, antral follicle count predict the quantitative aspect of the ovarian reserve. In women with undergoing treatment for the infertility, ovarian aging is characterized by decreased ovarian responsiveness to exogenous gonadotropin administration and the poor pregnancy outcome. On the one hand, correct identification of the poor responders by assessment of their ovarian reserve before entering in vitro IVF program is important. AMH level shows high correlation with the number of antral follicles before treatment and number of the oocyte retrieved upon ovarian stimulation. Several studies shows AMH is an excellent marker of ovarian responsiveness in IVF treatment. Lower AMH level less than 0.3 nanogram per ml predict poor ovarian response with a sensitivity of the 85% and a specificity of the 82.3%. AMH in PCOS more than 6.7 nanogram are associated with a high increased incidence of ovarian hyperstimulation syndrome. As you know that in PCOS patient there is more follicles, so more chances of the high AMH level, which may lead to the hyperstimulations. The PCOS is one of the most common endocrine disorder in the women of the reproductive age. It is characterized by an evolution manifested as a oligo or amenorrhea. Elevated level of circulating androgen and polycystic ovaries are visualized by ultrasound. Polycystic ovarian syndrome can elevate serum AMH concentration because it is associated with the presence of the large number of the small follicles. So factors that may influence serum AMH, factors that decreases AMH are increase in the age, increasing body mass index, administration of gonadotropin, and administration of the chemotherapy and radiation oophorectomy. Factors that increases AMH may be the PCOS. Factors that don't influence AMH may be the day of the menstrual cycle. It don't depend upon the day. GnRH agonist, oral contraceptives, and pregnancy. So IVF result in patient with very low AMH are significantly affected by chronological age. So very low AMH level are associated with a relevant risk of cycle cancellation. Live birth rate after IVF ICSI in the women with low and extremely low AMH, an age-matched control study, as this is displayed on the screen, that there was no difference in the outcome of IVF between patient with the low and extremely low AMH level. Women with the normal AMH level resulted in the high pregnancy rate as compared to the women with a low AMH level in the same age group. Age is important in determining prognosis of IVF in the patient with a low level of AMH. AMH, anti-Mullerian hormone, is correlated with cumulative live birth in minimum ovarian stimulation with clomiphene citrate. A retrospective cohort study displayed on the screen, it shows that the low serum AMH level correlated with low ovarian responsiveness, impaired pre-implantation embryonic development, and decreased cumulative live birth rate in CC-based minimum ovarian stimulation cycle. Therefore, the cycle success rate would be predicted by measuring the serum AMH level in minimum ovarian stimulation with CC alone. So there is a conclusion that serum AMH level decreases with the age in pre-menopausal women and hence the marker for the ovarian aging. Serum level of the AMH correlates strongly with the number of antral follicle counts, suggesting that AMH level reflects the size of primordial follicle pool. Assessment of the ovarian reserve is particularly important in IVF clinic, where the AMH may be used as a predictor of the poor response. Since a considerable proportion of the subfertility is due to postponement of the childbearing, measurement of the AMH level to assess the ovarian reserve may also be of interest in the women in the general. So the elevated level of the AMH in these women strongly suggests that serum AMH level may also be used in the diagnosis of PCOS. AMH level is strongly correlated with the size of follicle pool. Because of the lack of cycle variation, serum level of the AMH are the good candidate for the inclusion in a standard diagnostic procedure to assess other ovarian dysfunctions such as premature ovarian failure. So as you can see, the journey from the birth to the childhood, to the pre-puberty, to the adulthood, how the level ovarian reserve assessment can be done by ovarian reserve assessment, predictor of the menopause. AMH can be used. It is shown on the screen that the AMH can be used. How can be used in the different purpose from the birth to the childhood, to the adulthood, and the pre-puberty. That like to know the ovarian reserve assessment, predictor of the menopause, other fertility related diseases, application of the assisted reproductive technology, and potential diagnostic marker for the PCOS, and the fertility preservation program in the oncofertility and screening of the ovarian granulosa cell tumor. So it can be used for the various purpose from birth to the pre-puberty, pubertal age, and also very important marker of the ovarian reserves, follicle reserves, which affects the outcome of the IVF or ICSI treatment. I hope you can have some knowledge about AMH at present. Thank you very much. Any question?
Oh, thank you very much, ma'am, for the wonderful talk. We are very honored to have you and learning to hear you, ma'am. And ma'am, if you allow me, then we'll take the questions.
Okay,
Yeah,
go ahead.
thank you, ma'am. Ma'am, we have a first question, that is, how much is the cycle cancellation rate with the low MH?
In my practice, I can say only my experience that if we take 10 patients, 1 or 2 patients, we have to struggle by giving the higher and higher dose of the gonadotropin, because in spite of the low AMH, most of the patient insist that I am going to go for the baby with my own egg. That's why in my clinic, if I do 10 infertility patients, 10 patients to stimulate, then I think that in 10, 1 patient will have to go for the donor egg in spite of the stimulating higher and higher dose. So 10 out of 10, almost 1 patient can go for the donor egg because of the low, very, very, very low MH.
Thank you very much, ma'am.
Any question?
Ma'am, we have one more question, that do AMH have any role in predicting the in vitro embryo development potential?
AMH cannot affect the quality and the outcome of the IVF. AMH only decide how many eggs are going to form. It don't affect the quality. So it directly or indirectly don't affect the outcome of the pregnancy of the IVF, because result of the IVF depends upon the various factors, not depends upon the AMH only. It depends upon the endometrial thickening. What is the endometrial status? What is the quality of the blastocyst? What is the quality of the egg? What is the quality of the E2 and the P4 in this type of the ladies? So it don't direct affects the outcome of the IVF.
Yeah, thank you, ma'am. We have one more question, ma'am. What to do in case of poor responders?
Poor responders, there are so many Shanghai protocols is very best nowadays, in which we do the double stimulation, double pickup. So that is the best for the poor responders. Shanghai protocol.
Yeah.
We stimulate the patient in twice in the same cycle and retrieve the patient twice in the same cycle.
Yeah, thank you, ma'am. I think there are no more questions from the delegates. If you allow me, then we can close this webinar. Hello. Yeah, there are no more questions, ma'am.
Okay, thank you so much. Thank you.
Yeah, thank you very much,
Okay.
ma'am. We look forward for your continuous support for the upcoming educational activities as well.
Okay, thank you so
very
much. Bye.